Yeah, see, we are live.
Yeah, good evening, everyone. Welcome to this 86th masterclass today. So this series is on Mullerian anomalies and fertility problems. So yesterday's class, we spoke about classification of Mullerian anomalies and also about management of Mullerian anomalies in a novel way of classifying as presence or absence of part of the Mullerian duct, and also whether it is obstructive or non-obstructive. So if anybody has not seen it, please watch it so that it will be a continuum of yesterday's class. So in today's class, sir will be speaking about obstetric Mullerian duct anomalies, which I think we have seen quite a few during his visit to Bangalore, because these are the ones who are very young and who come for surgery because of the symptoms that they have due to the obstruction. So over to you, sir. You can take it from here.
Yeah. So I will start with the screen sharing only direct. Remember one thing, in obstructive anomalies, okay, the problems are very much more. Hmm? Just a minute. Yeah. Now it's visible, no? The screen?
Yes.
Okay. So see, we are trying to discuss actually fertility in obstruction. Okay. Now, what you should remember in obstructive anomalies is that there are many types of obstructive anomalies, but let me make it very simplified for you. Okay. For example, you have the vagina like this, which is opening externally. You have the cervix, uterus, fallopian tube, ovary. Correct? Now, obstruction means if there is a tubal obstruction. Correct. First of all, it is not a Mullerian anomaly, but the direct answer is IVF was invented for a tubal obstruction. So IVF is the easiest procedure to do in a tubal obstruction, and the simplest thing which you are going to do in the tubal obstruction is just knock it out. Just do salpingectomy. It is the treatment of choice. Nobody will feel bad about it also. Everybody will be happy also, and life will be very good. Okay. This is one thing which you have to keep in mind. Second is that there are some anomalies which are going to be causing certain unconventional obstructive symptoms. And the first thing which you should keep in mind about an unconventional obstruction is something called as a Robert uterus. What happens in a Robert uterus is basically, okay, there is going to be collection of blood which is going to happen beyond the obstruction because the endometrium is secretory, and there is going to be hematosalpinx also associated with that in many of the situations. Okay, so what are you supposed to do in a Robert uterus? Basically, you are never supposed to just cut it. You are supposed to excise the entire part. So once you excise the entire part which is present in the Robert uterus, the uterus then becomes a normal uterus from a Robert uterus. And the advantage is after it undergoes remodeling, okay, which usually takes 4 to 6 months, once the Robert uterus is completely excised out, okay, then in that situation, pregnancy can be easily achieved with either natural intercourse or with IVF based on the other parameters. Okay, so that is the thing which you have to keep in mind. Now let's assume we cross down one more milestone and we come to a pathology where there is obstruction here. Okay, now this obstruction is typically going to be classified as cervical atresia. Cervical atresia can be of two types. Basically, the whole cervix is atretic. Okay, so it is going to be either complete cervical atresia or it is going to be partial cervical atresia. That means a part of the cervix is seen, rest everything is incomplete. The most important thing is these girls are going to be very young because right from the first menses onwards, because there is a complete obstruction, there is collection of blood inside the uterus, and this is called as hematometra. Correct? You will experience the symptoms of hematometra. Remember one rule about hematometra. Hematometra is toxic to basal endometrium. So that is the reason you should not do any of the nonsense like giving lupride injection, giving dynogest. Oh, I didn't know only that somebody is operating this anomaly. So one has to really come out of that stupidity and operate these patients when they are young, as long as there is presence of hematometra. Because the earlier you empty the hematometra, okay, earlier you release the hematometra, okay, the better is the fertility outcome. Better fertility outcome. If it is a prolonged hematometra, you will see that in prolonged hematometra, even after a successful surgery, patients will end up having a secondary amenorrhea. And that secondary amenorrhea will be extremely difficult to treat because the complete basal endometrium which is present gets completely destroyed because of the presence of the hematometra. So that is just one thing which you have to keep in mind. Almost nothing can repair it. In fact, many a times people say that when the myometrium is thinned out, okay, due to hematometra, you can have thinned out myometrium. If there is a prolonged thinned out myometrium, then also there can be secondary amenorrhea. But the reason for a prolonged thin out myometrium is due to the destruction of basal endometrium, which causes a secondary amenorrhea to the patient. So please keep that in mind. That is a very, very important thing about cervical atresia, which you have to keep in mind. Surgery for cervical atresia is very, 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 very tough. Okay, because you are trying to canalize a muscle, okay, which has never been canalized. So what happens is, even if you canalize it correctly, the problem in long term is stricture. So many a times people will put a silicon bulb and all these things inside, including me. But what we have realized over the last 40 or 50 cases of cervical atresia, which we have done, is you should never put a canalization through the cervix. You should just do something called as trachelectomy. Okay. You should only do trachelectomy. Now, once you do trachelectomy, that means the cervix is released. You don't care a damn about canalizing. You are straight connecting the internal os to the vagina. If you connect the internal os to the vagina, then life is easy. Only thing is there is risk of incompetence. But apart from that, the patency is never going to be an issue. And this we have now proven multiple times. Okay, otherwise, what will happen is when you put a silicon bulb, many a times this silicon bulb will drop down. Okay, and if you do not maintain this patient on a sixth monthly follow up, okay, if you do not do this, 100%, more than 80% of them will end up with a repeat surgery where you will end up doing a hysterectomy. Okay, so please don't do that. Please don't do that, because cervical atresia is something which can be easily managed, beautifully treated. The golden line is, when you have a cervical atresia, the patient has to be treated young, and that is very, very, very important for you to understand. Okay, now let's move down. I will just erase all the things which I just spoke, because I'm sure everybody would have uh, understood. So I will just erase this fatafat. Okay, now comes the beauty. Now see this cervix, no, has a beautiful musculature. So what happens is, you have a uterus, everything else is okay, correct? Problem is nowhere in this tract. Now the problem is in this tract. That means the problem is in the vagina. So please remember, vaginal obstruction, okay, is basically into two parts. Either it is a septum or it is a atresia. Okay, so if there is a septum, what is the meaning of transverse septum? Transverse septum is not going to be like this. Transverse septum matlab, transverse septum can be like this. Okay, remember, it is never going to be कि हाँ transverse septum है, मतलब सीधा एक डंडी है. But the thing about transverse septum which you have to keep in mind and which you should understand as a part of this lecture is that when you have a transverse septum, see, this musculature is intact. Can you see? The cylindrical musculature of the vagina is intact and there is a septum. So you have to go and excise this septum. Matlab, this whole thing has to come out, and if need arises, you can take one or two sutures here and here and then keep a simple Riles tube mold inside it. The mistake which people do is they incise here. Okay, and then they think that the transverse septum will heal on its own. Never, it will happen. This septum has to be completely excised. The golden rule is just excise out the septum. It has to be excised out, and this has got excellent fertility outcomes. Excellent is the word, because any form of hematometra which is getting collected here, okay, I am telling you, this internal os, the cervical canal, is a strong sphincter. It is basically a very strong type of a sphincter. So just keep in mind, nothing can go in the uterus. Because nothing can go in the uterus, there is basically going to be no hematometra, and the uterine fertility is going to be excellent even if the transverse septum is prolonged. See, I think Dr. Shilpa will tell you that we have operated in Bangalore transverse septums which are operated 2-3 times before. Okay, and the fertility outcomes are excellent, because by the time they reach us, 2 or 3 people would have already nicked it here, understanding, and it will keep on recurring. That is the explanation of the transverse septum. Now comes the more dangerous part, which is atresia. See, the big problem in atresia, okay, which people again fail to understand, is that you have cervix. Let's say you have this. Okay, now the blood which comes from here actually needs an exit, but if this exit is absent, okay, if this exit is absent, then it will keep on getting collected inside and it will form a hematometra. This will again happen very very much in the young girls. The biggest or the commonest thing which you are going to see is something like this. Okay, this is called as mid vaginal atresia. Mid-vaginal atresia requires a complex reconstruction with something called as partial rectal pull through, and the rectum has to be pulled out, because only once the rectum is pulled out, you will be able to pass a silicone bulb out into the vagina like this. Okay, and you will be able to patch the rectum posteriorly. Okay, only in that situation there will be recanalization. Okay, and this is a very difficult surgery, because you need to ensure in this patient that the rectum is also patent. Basically, the neovagina, basically, which you have created, is also patent, and you have to ensure that the hematometra, that means the uterus, is also patent. Both these things. This is a little tough uh, reconstruction to do. This is a long standing reconstruction to do. This requires a 6 monthly assessment. And we have shown this even on Facebook Live surgeries, and the people who have come to observe our surgeries have already seen it. So you have to keep this in mind, that this is a very, very important anomaly. This is a common anomaly. In fact, this is the commonest anomaly which is seen in young girls with hematometra, and one has to get it treated by whomsoever whom you consider to be an expert. Okay. And finally, before I conclude, there are certain special anomalies which are called as, again, we have done a lot of these cases everywhere. Okay. See this. Actually, two vaginas are there. Correct. Then there is a differential canalization. Now, unfortunately, sometimes what God does is God just creates something called as a hemi vagina. Okay. That means the lower 1/3 on one side never canalized only. So because it did not canalize, it leads to something called as Ovira syndrome. Okay. This Ovira syndrome, along with this, is also going to have absent kidney on that side. So let's say this is going to be a right side and left side. So Ovira syndrome with a right absent kidney. That means the hemivagina which is present here. This hemivagina is going to be present on the right side. The most important thing in this hemivagina is that it is going to cause a bulge here. So when you actually look at the picture of this hemivagina, it is going to be shown as something like this. You will see this bulge, okay, because that entire anatomy is going to be altered. What do people do? Commonest mistake. Okay, people do this. Khachuk, they will make a small nick here, and then they will forget everything. The important thing is you are supposed to excise this entire septum. Huge excision is required. Okay, you have to excise of this entire septum. So what will happen is, once you excise, there will be so much hematometra which drains out, and the vagina will remodel into something like this. Got it? This is how the vagina will remodel. The point from here to here has been completely excised, and you will give the uterus two excellent tracks. Now, after this surgery has done, these patients will usually conceive naturally because this is otherwise a didelphys uterus. Okay. And finally, before I conclude, I will just show you some other obstructive anomalies which are commonly seen in our practice, but they have an extremely easy management because they have got nothing to do with fertility, but they are obstructive anomalies. So you have something called as bicornuate uterus, where vagina and everything is absolutely normal, and you have a rudimentary horn which is non-communicating. Okay, functional but non-communicating. If it is a functional rudimentary horn but non-communicating, it will form a large hematometra inside. Patient will have severe dyspareunia, and in that particular side, the fallopian tube will be a large hematosalpinx. Basically, it will be a large hematosalpinx with endometriotic cyst, and this requires excision from here with a reconstruction of this particular horn. Okay, and that is the last anomaly which we need to keep in mind, because a functional rudimentary horn is an obstructive anomaly, but what it does is the other side is absolutely normal. So when this other side is absolutely normal, this patient can either conceive naturally, or then it can proceed with any, okay, any other methods which it chooses in order to have conception. Okay, so with this, I cover almost the basics of all obstructive anomalies with their correlation of fertility. Okay, remember one thing. What is now important for people to note? Whenever we are doing IVF in patients in whom you are doing neovagina plus uterine anastomosis, okay, this IVF is very tricky to do because the endometrium lining is going to be very difficult for us to assess. The biggest problem is you are supposed to pass a probe into the vagina. Okay. And when you pass a probe into the vagina, it has to go and touch that cervix for you to analyze the cavity very nicely. So, in my opinion, what typically happens is that doing IVF is very tough in these women. Okay. If these women are to conceive, these women will conceive naturally. Okay, we are going to be demonstrating in next week. Okay, our 12th, I think 12th pregnancy which has happened out of cervico-vaginal anastomosis. That is one patient where there is only cervical atresia. Understanding? So you just do trachelectomy, vagina was normal, easy to pass cuspo speculum, uterus was normal, easy to pass the speculum. I mean, easy to pass the embryo transfer catheter. I am talking of great difficulty which is encountered in patients who are having neovagina. That means a partial rectal pull through has been done for the vagina. And along with that, you are supposed to do an embryo transfer. Very tough. In my personal opinion, I have done only two patients so far in my entire life. Okay, where we have attempted an embryo transfer. Uh, I will tell you one thing, embryo transfer happens. Okay. But both the patients have ended out as negative. I mean, both of them have not conceived. One has even gone and done adoption, and the another one ended up in hysterectomy only 30, 40 days back. Okay. So, um, that is something which I just wanted to share, because despite doing such fantastic surgeries, the great thing I'll tell you, the most happiness, the most maximum happiness these patients are getting is because they are getting menses, and they are able to have a wonderful sexual intercourse because the vaginal length is very good. Okay, the problem is fertility, and problem is even if the uterus is menstruating, you will be in that impression is uterus is very good. Okay, but there is something which is technically wrong in that Mullerian tract only. Okay, and because there is something which is technically wrong in that Mullerian tract, it is very difficult to do the embryo transfer. So when people talk of these rocket science things, no, that they do intramyometrial transfer and all that, they will not be able to locate the uterus only. First of all, whenever you have an Mullerian anomaly, because the location of the uterus is very, very different. I will tell you why. Because once you do a partial rectal pull through, uterus is located way down. The vaginal length, no, after let's say 2 years, 3 years of partial rectal pull through, now we have that experience, is not going to be 10 centimeters. Okay, it is going to come down and it is going to become 8 centimeters. So when the vaginal length becomes 8 centimeters, you will feel the cervix with your finger, because finger examination will be very easy. So you will feel the cervix through your finger. The problem is, in order to put the embryo transfer catheter inside, you need a cusco speculum to see where that cervix is. And when you put the cusco speculum to see where that cervix is, it is very tough to see because patient can't tolerate it. Understanding? Which is a big problem. I'm just telling you the practical experiences, okay? But yeah, this is what we have seen. So with this, I conclude. Shilpa, madam, you can shoot your questions.
Yeah, just two, three questions. So in obstructive Mullerian duct anomalies, we see a lot of associated endometriosis as
Compulsory it is.
yeah, yeah. So in this, which are the cases that you decide to salvage fertility, and how do you decide that they will go for hysterectomy? So we have done in Bangalore, I think, more than like 25 cases of Mullerian anomalies easily. And many a times on table, we have seen that it looks really bad. And we have taken a decision to do hysterectomy also in one or two cases in Mullerian anomalies previously operated two, three times, though they were unmarried. So how do you take that decision on table that you would go for hysterectomy?
That is because usually when we come to know that it is a very, very bad uterus, isn't it? Completely gone, myometrium is thinned out, patient has been operated 1, 2, 3 times, and then the patient has come to us. Everything is fibrosed everywhere. First, we have to cut the fibrosis, then we don't even know if the anastomosis will hold on, isn't it? In that situation, girls who want to experience menses, what we normally do is we can try to do a sigmoid vaginoplasty, they will get menses. But the problem is the ascending bacteria which go from the sigmoid into the uterus will completely sort of kill that uterine endometrium. Okay. And if it causes that, then it is very, very bad.
So how to differentiate between vaginal atresia and septum? You remember last time we had this
Per
young.
rectal examination, madam.
So what do you feel? You feel a tight band kind
You
of.
you won't feel the vagina.
Oh, okay.
It will straight go into the bladder. I mean, your finger will start feeling straight into the bladder.
You think that is 100% accurate, or
Yeah, very much accurate. The only problem which occurs is if there is a hematocolpos which is developed in the upper vagina. That hematocolpos will press down, so we will think that vagina is bulging. Understanding? And when we think that the vagina is bulging, it is becoming difficult to examine the level of the mid vaginal atresia. Okay, so that can be a practical difficulty, but otherwise, I think it's okay.
no? I think last time we saw this girl who was diagnosed as transverse vaginal septum and tried to canalize by resecting that septum
Yeah,
elsewhere. We
yeah,
saw it was atresia. Uh,
yeah.
s- I think the accuracy by MRI is not that great. What do you think?
See, MRI is dependent on who is reporting it, madam. And the problem is the distortion of anatomy is going to be so high in quite a lot of these cases that it is nobody's fault, madam.
So the renal anomalies are very common in Mullerian problems. So which are the cases that you have seen commonly associated with Mullerian the renal problems commonly? I mean, it is not specific, is it? Ovirato, anyways, we classify it as syndrome only when there is a renal.
Renal agenesis.
But apart from that, I mean, like ectopic kidney or like, absent kidney, all those things, like you see it very commonly, right?
Ectopic kidney is very common, madam.
Mm-hmm.
Because these are all, as I said, these are disorders where some amount of migration is also a problem, no? So kidney also has to go up. Kidney, it should not be कि over is going down, chalo मैं भी आता हूँ. I will also come down. All these types of things will happen, no? Because when they are growing together, they are like that brother atmosphere, no? Paramesonephric and mesonephric duct are so close to each other that एक को कुछ problem हो गया, दूसरा भी रोने को चालू करता है, something like that.
Okay, so this Robert's uterus, you were mentioning that we have to excise that whole thing,
Yeah.
the septum. That is through hysteroscopy, obviously, that you will be excising that thing. But I don't think like, it is like an oblique or it is like a proper transfers or anything. I mean,
Never.
so how do you like, how do you go ahead and know like how much to excise? Is it by tactile, the sensation that you will start feeling the muscle?
No, you will feel that bulge, no, madam. When you go inside that uterus, you will feel that bulge and it will be a big bulge. It is not a small bulge. The one that bulge which comes is a very big bulge. So what happens is first you have to wait for that bulge to become more, and then peel it off. Understanding?
What's the difference between Acum and Robert's uterus? Robert's uterus is a Mullerian defect.
Endometrial. Robert uterus is basically endometrial. Accumes is myometrial.
So among these, you said the cervical agenesis, whether it is partial or complete, that's the toughest to treat among all the obstructive anomalies, right?
Yeah.
And is there a way that we can maintain the patency post op when you have like created the vagina or like you have canalized in
Hmm.
partial vaginal, sorry, in vaginal atresia or in like cervical agenesis when you do the end-to-end anastomosis. So I think the important thing is like to maintain patency post surgery. So is it just like any other MRKH where you do the same thing like Riles tube, mold and all that?
Same.
I'm very
Same.
similar. Yeah. Okay. So you are saying in obstructive, there is no age bar where we have to like wait and then do the surgery. The
Early.
earlier the surgery, the better it is. Yeah. Okay. Yeah. It was wonderful. Thank you. I think you have immense experience in doing the surgeries for Mullerian, and I think that is why the outcomes are so good. So thank you very much. Thank you. Tomorrow we'll do the non-obstructive.